Hi everyone. Welcome to this AIUM medical student webinar on ultrasonology, the study of clinician-performed ultrasound, presented by Dr. David Bahner. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the end of the presentation, participants will distinguish various terms related to ultrasound. Participants will also be able to utilize the framework of AIUMS to approach a point-of-care exam and facilitate a common language to communicate key components of performing an ultrasound exam. As an ACCME accredited provider, it is the AIUMS policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Bahner and Kathy Minton have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now, we're pleased to present Dr. David Bahner.
Thank you, Kathy. Welcome to all my listeners. Here we go. Thank you, Kathy, and thank you, AIUM, for this opportunity to present to you all. The topic today is Medical Student Lecture Series, Ultrasonology, the study of clinician-performed ultrasound. I'm David Bahner. I'm a professor of emergency medicine at the Department of Emergency Medicine at Ohio State University. I don't have any disclosures, but I did get an equipment loan with some ultrasound to take to Antarctica in 2016, and we took it to the top of Kilimanjaro, a Philips machine, but no financial compensation was delivered. I want to start with this slide. This is the human connectome. For those of you that have not seen this, if you could Google this tonight, people have talked about how their brains are wired. Well, researchers for the last 10 years at NIH have been looking at various forms of neuroimaging to see how the connections of the human brain are connected from the white matter tracts to the gray matter cells, and I think this will help us shed a light on the black box of memory, learning, and many things in the future. I'm hoping that today that I can change your mind about a couple of things with ultrasound, and you may learn a few things, but if you could look up the word connectome, it's an important word in the near future. This is an ultrasound image, and most people look at these and think that it looks like a polar bear in a snowstorm. It has grays, blacks, and whites. It has marks on the side indicate the indicator, pictures, specifications. Yet many people don't know how to utilize ultrasound. So the objectives today is that we want to go over some definitions, but the main one is I want you to understand what a sonologist is, a person that acquires and interprets ultrasound images and uses it in medical decision making. We want you to use the AIUMS method if possible. We wrote a paper on how to approach a focus ultrasound exam, the indication, the acquisition, interpretation, and medical decision making. And then talk about a common language, especially about probe motion and how to perform ultrasound. So we all know that ultrasound has benefited from the technology boom, and it's become palm size. The price point has decreased. This is one device by GE, but there's multiple out there by Philips and others, and Sonosite and others. The devices are smaller and you're able to take it wherever humans go, but the technologies outpace the education, and many people don't know how to perform, acquire, or interpret. Another thing that I noticed while going to some of these remote locations, that the battery life is short, and really it can be a challenge in remote locations. Wherever you are, you have a probe and it has an indicator mark on the probe that shows you what side is the leading edge. I always think that there's the patient, the anatomy of the patient, the probe, and then the picture. Well, the picture is going to be this beam that comes out, and the beam has top, which is the near field, the bottom is the far field. The left side at our institution is the leading edge, and on the right side is the receding edge. A lot of these conventions we have established here at Ohio State and have written papers about this, but there's multiple ways that people will put the indicator. For example, in cardiology and anesthesia, someone will put the dot over here on the right side. In Mayo and others, they sometimes will put the images reversed and shot from below. But we've established these as the left side is the leading edge and the right side is the receding edge. So you have the patient, the probe, and then the picture. And you get a picture, and it's a two-dimensional representation of a three-dimensional structure of the human body. This image is a transverse cut through the abdomen and shows you the anterior near field with the rectus abdominis muscle. We have the liver, the pancreas, the vertebral body. The left side of the image is actually the right side of the body, and the right side of the image is the left side of the body. So in a general term in radiology, it's as if you're looking from the feet up. So for example, we have this vertebral body here, and we have an anechoic structure here, which is the abdominal aorta. It's on the right side of the image, but it's on the left side of the body. So understanding the way that the image is generated and put up on the screen is so important. And ultrasound is known as operator dependent. There is different types of ultrasound that have been performed, focused and comprehensive. The term focus has been recently, it means a clinician-performed ultrasound used at the bedside, now been branded a point-of-care ultrasound, versus a comprehensive ultrasound, which is a referred exam that usually goes up into a imaging suite. There's a sonographer that acquires images, and then an imaging specialist that interprets it and gives it back to the clinician to help with medical decision making. Ultrasonography is the writing of using ultrasound images, the acquisition of ultrasound images. There's in the United States many societies for sonographers, the SDMS and the ARDMS, for the acquisition of ultrasound images. Ultrasonology is a term I've heard, but there's no actual official definition I can find in Merriam-Webster or any of the dictionaries online. And I'm going to talk a little bit about this, but my definition of ultrasonology is the study of ultrasound and truly the study of the acquisition and interpretation of ultrasound images in medical decision making that can be used at the bedside. So since there's not a significant term or definition for this ultrasonology, tried to adapt it to some of the uses that we see. So when we are training ultrasound, we've been training ultrasound to various learners for over 20 years, is you have to start early. You challenge the learner. Deliberate practice is the most important thing about learning this skill. That's from Malcolm Gladwell talking about 10,000 hours to become an expert. That's from Anders Ericsson's work that talks about putting the time in to get familiar and become an expert. Nowadays we can use simulation online, have various review sessions, hands-on skills training. And the whole thing about ultrasound, which has been the challenge, is the assessment of competency. So early in my career, developed what I call the ultrasound educational competency hierarchical outcome. And basically is a graphical way to look at competency. We know that there's novices out there, basic, intermediate, and advanced as far as their knowledge of ultrasound. And most times that is based on your knowledge on your x-axis as you're going from high school, college, medical school, a temporal axis on the x-axis. But with ultrasound, it really is this z-axis, the number of exams you performed, how many diagnostics you participated in. And so this really is the determinant of competency. When we look back at the history of some of these words, back in 1981, Art Fleischer, looking at neonates with ICH, talked about the importance of a cooperative team effort with an ultrasonologist, which is an imaging specialist that's able to acquire and interpret, and an ultrasound technologist, the sonographer. So this term has been around for over 3 decades, yet it's not totally clear what that word means, ultrasonologist. In 2007, with the portable ultrasound, this article out of Italy talked about more individuals and practitioners being able to use portable ultrasound, and they were part of the Society of Ultrasonology. So when you look into the international scene as far as the term ultrasonology, it's used, and it's sometimes overlapped with ultrasonography. And I think that there is a difference. Sonographers acquire images, while sonologists acquire and interpret. So it's an expert in ultrasound. So kind of an expert, start your expertise, it's really getting some basic principles down and some of the physics. Ultrasound is defined as sound waves above the range of human hearing. Human hearing is between 20 and 20,000 hertz, or cycles per second. This is what our cochlea is tuned into. Our cochleas can hear between those frequencies. Greater than that is ultrasound in the kilohertz, but when you get up to the megahertz, that's what we use for diagnostic medical applications. In general, a 3 megahertz probe is a common probe that's used. There are some probes that are can go up to 40 megahertz. Those are more used for research, but commonly 2 to 15 is the frequency for most diagnostic medical ultrasound applications. Ultrasound can be used both diagnostically and therapeutic. And all sound waves will either, they attenuate, they can either reflect, refract, scatter, or absorb. So as the sound waves travel through matter, they'll do one of those 4 things. And those 4 things will cause the sound waves or the mechanical waves to weaken with distance. This weakening is common to all waves, not just mechanical waves. This is probably the most important slide of the talk. This is out of RUMAC's Diagnostic Ultrasound 3rd edition. It talks about the attenuation of common tissues. So all tissues, all matter will attenuate, reflect, refract, scatter, or absorb. The units that this graph is in decibels per centimeter per megahertz. And so it's a mathematical way to look at the attenuation coefficient. And I just find this interesting because if you look at the top 2 with attenuation coefficient with no attenuation, no reflection, refraction, scatter, absorption, the molecular structure of water, the sound waves travel through it and have full transmission. There is no reflection, refraction, scatter, absorption. Blood cells have a little bit because you can see sometimes the blood cells, and so they'll reflect, and you can sometimes see those on grayscale. But basically these 2 things on ultrasound are black or anechoic, no echoes. These next 6 are gray or hypoechoic, low amounts of echoes, fat, soft tissue on average, the liver, the kidney. I want to point out muscle in long and short axis. When you go with the grain of the muscle, you have less attenuation. When you go against the grain, you're hitting all those fibers and having more reflection, more scatter, more refraction, and the attenuation coefficient is higher at 3.3. And I want to point your attention to these last 2, bone and air. Bone attenuation coefficient is 5, so it's a strong attenuator. It's a strong reflector. It reflects the signal and leaves a shadow behind it. That's because no ultrasound wave can get through the bone. Air, on the other hand, is white, also hyperechoic, but it's a strong scatterer. And if you think of the molecular structure of air with the molecules of air and oxygen, 78% nitrogen and 21% oxygen, the molecules are so far apart that the ultrasound waves will hit it and scatter. So both of these are white, but bone is a strong reflector while air is a strong scatterer. The point being is that if you can understand these concepts, that sound waves will transfer their energy from molecule to molecule, and when you have all the molecules right next to each other like water, it has full transmission. When they're scattered apart, like air, they cause lots of echoes and lots of attenuation. The bottom line is if you put black or gray things in the near field of an image, you can see in the far field. It's called an acoustic window. If you put white things in the far field, in the near field, you cannot see things in the far field. So when we look at ultrasound, how it developed, Lazzaro Spallanzani in the 18th century saw bats, and bats would navigate using high-pitched sound waves outside of human hearing. He termed this ultrasound. In this picture of the bat, you can see as it rotates from In a tree, you can see as the light illustrates the veins on its wings, and the bat uses sound to be able to see and navigate through his environment, his or her environment. As humans, we use our retinas, and our retinas can be tuned into certain frequencies, light waves. There's electromagnetic waves at different frequencies. Low frequency at the radio waves can travel great distance. Then you have microwave, infrared, light waves, or Roy G. Biv. At the end of violet is ultraviolet, then X-rays and gamma rays. So electromagnetic waves, such as the sunset down in Antarctica, is usually formed from various stars. They can travel great distances. They travel the same speed, the speed of light, but they also will attenuate and reflect, scatter, and absorb. Mechanical waves, like the ocean here, needs matter to travel through. They travel at the velocity based on the matter that they're traveling through. This propagation velocity through air for mechanical waves or ultrasound is 330 meters per second. Through soft tissue, it's 1540 meters per second. Through bone, it's 4080 meters per second. But electromagnetic waves travel at the same speed, the speed of light, 3 times 10 to the 8th meters per second. So when we look at the history of ultrasound, it started back with Donald Howry and others back in the early 50s using this water bath to try to image. These are an early ultrasound image from the 1960s. This is from Joan Baker. This is a fetal heart. This is motion mode, where the x-axis is time, the y-axis is depth, and the z-axis is the brightness of the echoes. You can see this waveform. This is a fetal heart of a baby using ultrasound. Ultrasound progressed in the 50s and 60s and went from these 2 to 4 to 8 shades of gray to where it is today, and now it has 256 shades of gray that we can actually distinguish some of the structures. It's a lot easier when everything is labeled. This is a common view, the right upper quadrant view, where the probe is rotated just briefly to lead edge toward the bed to get in between the rib shadows. Here's a rib shadow that's black, rib up in the near field. We have the fascia. We have a liver, which is hypoechoic and gray. The diaphragm is hyperechoic and white. Here you see the spine in the far field. It's hyperechoic with posterior acoustic shadowing. The spine stops at the diaphragm because there's air in the normal lung, and the air does not allow the transmission to see the spine that goes above the diaphragm. You have the kidney, the right kidney here, and there's a potential space here called Morrison's pouch where fluid can collect. And we have the psoas muscle back here. So every ultrasound image is going to have 4 sides, top, bottom, left, and right, near field, far field, leading and receding edge. And then it's going to have 3 colors, black, gray, and white. I'm trying to figure out what those structures are. In medical education, there is much training for how to practice medicine, but not as much training for ultrasound. At the UME level, or undergraduate medical education, this is medical schools. Currently, in recent studies by VDIN, 1/3 of medical schools have ultrasound, 2/3 do not. At the residency level, most programs have been exposed to ultrasound, at least the practice. Maybe it's comprehensive, but have ultrasound in residency. And then as we graduate from residency, become attendings, and you have to continue medical education. And in America, they have what they call maintenance of certification. All 3 of these are ways that students and learners go from being a student to a resident to attending physician. Ultrasound is not coordinated among these 3 on a master level, because I do not think that they have branded this effectively. That's why I think that the new term of ultrasonology is applicable to try to help people understand what we're trying to develop, which is clinicians are able to perform ultrasound. But at each level here, there's ultrasound that is happening, but it is not coordinated between these 3 areas. A paper we wrote in 2014 said, what are the barriers to putting ultrasound into undergraduate medical education? So these are the top 5: lack of space, lack of financial support, lack of ultrasound equipment, lack of trained faculty, and lack of student interest. I didn't think that this last one was applicable in my experience, but in some areas maybe there is lack of student interest. But there are barriers, and these can be overcome. It's a lot easier in 2017 to put ultrasound into a curriculum than it was in 1997 when we got started here at Ohio State. We started and eventually went into vertical curricula. where at each level, Med 1 through 4, there was core, that all the students got access to some core procedures and skills, while the motivated or the enriched would do these other programs. Most of these have been written up into the literature. For example, our TSEP program is a model pool for second years, and that's been written up in JUM. The honors program was written up in academic medicine. But the concept that really happened was just trying to put ultrasound at every level of undergraduate medical education to try to provide an opportunity or scaffold for students to learn. The technology, what's the next must-have device, and how are we going to use this? This is the vascular access phantoms that we use to try to train all the students and then the residents and fellows how to guide a needle to a target. The key thing in a short axis is keeping track of the needle tip. When I first started, we didn't put lines in with ultrasound, but that is commonplace now, but is not standard for every line placed. I don't believe in the United States that they're all being done with ultrasound. I think that it's 50 to 60%, the last I saw. This whole concept is what a gentleman named Everett Rogers back in the 1960s talked about, the diffusion of technology. That any technology has to diffuse into a cohort of people, and that there's steps associated with that. There's innovators that are early to the game. There's early adopters, early majority, late majority, and laggards. For example, if you're not on email today in 2017, you're probably a laggard. But if you're not on Instagram, that may be at the early to late majority phase. With ultrasound, it was not only the technology that had to diffuse into medicine as it got smaller, but the concept of point-of-care ultrasound or clinician-performed ultrasound. So I think there are two things they were trying to diffuse into medicine, and that hasn't diffused equally across institutions or specialties. So this article 6 years ago in New England Journal of Medicine, Point-of-Care Ultrasound, by Josh Capel and Chris Moore, talked about all the various specialties that could use ultrasound and some of the various applications. Out of all these, emergency medicine has a scope of practice and decides what each of its operators needs to learn by the end of training. Most of these other specialties have described ultrasound in either case reports or in its clinical use, but many of them do not have a codified scope of practice of exactly what every trainee needs to be able to perform. At Ohio State, we have tried to put ultrasound into medical education and change the culture and really develop sonologists. This pictures of three of some of the trainees. Peter Croft was a medical student that graduated from medical school here. Nick Thiuni is a medical student that's now at Michigan. Peter went up to Boston. And Eric Adkins is an intensivist that is now faculty here. These were when they were students and fellows, and training them on how to use ultrasound to acquire and interpret and use it in medical decision making, starting early in their careers. Now Peter is teaching, starting a medical student program at Tufts, and Nick is up in Michigan running the fellowship. This ultrasound expertise that they developed and started in medical school over time with lifelong learning has made them experts, and so we're training them to become sonologists, and they become that. So this concept that we have tried to graphically represent here is what I call the tree of ultrasound knowledge, that all clinicians will start as medical students down here at these roots, and at Ohio State we have what we call the LSI curriculum, Lead, Serve, and Inspire. So these are the branches of the LSI preclinical curricula, years 1 and 2. At year 3, before they start their rotations, all the students will do what we call a ground school to get them familiar with procedures, and we do that here with all the students in their 3rd year. Then during their 3rd and 4th years, they're trying to develop into their specialties and defining which specialty they want to go into. And there's various specialties that are using ultrasound, and these are the branches. We try to designate a branch manager, pun intended, to be a community of practice leader, to reach out to residents and faculty in their area and reach down to students interested in their specialty, to try to coordinate their activities for clinical care of patients, education of learners and workshops, research of new knowledge in the literature, and the administration of programs. So this concept of this tree of ultrasound knowledge tries to say the whole field of medicine is using ultrasound, starting as students, turning into senior students, going into residency, and then outward onto this tree. The size of the tree is based on how sophisticated it is and the thickness, beginner, intermediate, advanced, and honors, sort of like rings on a tree. So if we go back to these branches, the emergency medicine branch is a really thick branch. At every program across the country, there is protocols and faculty and leadership. At other branches, it depends on which institution you're at and what ultrasound champions there are. So our ultimate goal is to have a multi-level curricula that we have radiologists, anatomists, sonographers, and all the various specialties participating into a multi-level ultrasound curricula at the medical student level. We're in the process of doing that and trying to mentor others in other specialties. We try to help them whenever they're trying to develop a curricula using Kern's 6-step method of designing a medical curricula. This is out of Hopkins Press. And you try to identify the ultrasound curriculum need, and that really in all the specialties a basic and advanced competency. Evaluate your internal and external resources. Develop the curricular goals and objectives for your specialty in your area based on your scope of practice. Develop the curriculum content and use that on online materials that they can flip the classroom, some type of simulated center or where they can get hands-on experience, and then a clinical experience with real patients where they can see pathology. Coordinate that curriculum and evaluate and revise that curricula. These are the steps toward designing a curricula that's effective. We published a paper years ago called the AIUMS. It was a way to not only teach focused ultrasound, but also a way to codify the steps in performing ultrasound. For example, in emergency medicine, we have over 11 indications to perform ultrasound that include trauma, flank pain, hypotension, pregnancy, so forth. And the indications are why are you performing the ultrasound exam. The acquisition, which sonographers do very well, is how are you obtaining the images. Is the patient getting the patient set up in the right place with the rails down, the lights down, selecting the right probe, optimizing the picture, following the protocol, and recognizing the various pathology. You get the images, then you have to interpret them. What are the findings? And I have our learners ask 4 questions. What color is it? There's 3 colors, black, gray, and white. You should have a differential for each of those colors. What shape is it? Is it in like a vessel? Does it look like a tube and long axis, a circle and short axis, or an ellipse and oblique axis? Where is it located? The near field, the far field, the leading or receding edge? And finally, what's important in imaging is what is it juxtaposed to? So an anechoic structure inferior to the liver with a blind ending pouch without flow is a gallbladder. That juxtaposition of the gallbladder and liver can help you. And finally, the decision, the medical decision making, how do I use these findings in the care of the patient? So for comprehensive ultrasound, the clinician knows ultrasound needs to be done. They order an ultrasound. The sonographer acquires it. An imaging specialist will interpret it. And at the end of their report, they'll say clinical correlation indicated and give it back to the clinician to make the medical decision making. 3 people involved in a comprehensive exam, while focused exam or point of care exam, the clinician knows the indication of why it needs to be done. The clinician acquires images. It's not overread by a physician, but interpreted extemporaneously at the bedside by the clinician, and they use it for medical decision making. This is the paradigm shift that's happening, and I think is the basis for what I'm calling ultrasonology, is developing sonologists that can use ultrasound to perform at the bedside. So one of the first focus exams that happened started in the 70s and 80s in Germany and Japan, and then became codified into what's called the FAST exam, the focus assessment with sonography for trauma. We remember at our institution is 4 Ps, the pericardial, perihepatic, parasplenic, and posterior cul-de-sac. What it's trying to do is look for potential spaces in the body where fluid can collect. And it's asking a dichotomous question. That's what focus ultrasound does. Is there fluid or not? Yes or no. Not asking complex questions. So the FAST exam is something that has been we've been performing and teaching for over 2 decades. And this is back from the 20th century at the bedside doing an ultrasound on a trauma patient, where you can make clinical decisions on some of the sickest patients. And I think that's why point-of-care ultrasound has really grown, for its applicability in those situations. So when we look at this closer, the acquisition of ultrasound images means get the patient in the right position. That means you can have them roll, have them draped with towels, put the rail down, and they get the lights down in the room. This is getting this equipment set up, including plugging the machine in, selecting the right probe. Using low-frequency probes gives you better penetration. High-frequency probes give you better resolution. Certain probes are focused for small parts in various structures. There are the various probe motions that we're going to go over on how to move the probe and how to center an image. Looking at the probe itself, in which is the leading or receding edge, and doing the indicator test by touching the tip of the probe and seeing which side is the leading or receding edge. The optimization of the picture, there can be non-knobology things to optimize the picture, such as more pressure and more gel. But then there can be knobology, the study of knobs or the buttons. Those can be confusing. I would say a strategy is to have first things first, second, third. So have a strategy of 1, 2, 3. Primary, to try to improve the image, depth and gain. Maximize your depth so the things are as large as possible, and turn down your gain so that the black structures that are supposed to be black are black. If that doesn't work and your image still needs help, you can, the secondary things is look on for frequency and focal zone. Use the highest frequency possible to get the best image, and then put the image of interest, put the focal zone into image of interest. If that's still not working, then there's some tertiary things that you can use, such as dynamic range. Higher dynamic range is a smoother image, while low dynamic range is a grainy image. Tissue harmonics or grayscale maps. But the point is the knobology in the picture can be optimized by having a systematic way that you do first things first, depth and gain, and then if that's not working, F and F, frequency and focal zone, and then dynamic range, grayscale maps, or tissue harmonics. It is not important that these things are done in order, but just that you personally have a scanning strategy. And finally, you have to do the protocol. Unlike comprehensive ultrasound scans, focus scans do not have rigid protocols, yet the fast scan is the most organized because it has 4 views that you do. But for example, soft tissue for an abscess doesn't say that you have to save 15 images. It's basically what we teach is that at the very minimum you need a long and short of the structure of interest, a video, and making sure you put labels. But the acquisition of the images is so important, and for a quality image, the acquisition is the hardest part. Interpreting images, asking those questions of what color is it? Black is anechoic. Those are going to be low attenuators, things such as fluid or artifact. Gray is going to be tissue or artifact, and white or hyperechoic structures are going to be dense tissue, such as bone, the diaphragm, fascia, or air. Air on ultrasound is white. What shape is it? There's 3 shapes in the body of every structure, long, short, and oblique. There's one long, one short, and 178 integer oblique axes. Where is it located in the image and what's it juxtaposed to can also help you. You have questions that you can ask. What does it look like in long or short axis? As you try to get a 3-dimensional feel of that structure, you can get a better understanding of what it is. A stationary video means you hit clip and you don't move the probe and you let the body underneath move, and you can start to see the physiology and the structure and function of. How does it respond to pressure? Abscesses will swirl. Look at, this is not talking about tissue elastography, but just on B mode, how does it respond to pressure? Does it have flow? If something is anechoic, is it a vessel? So again, the grayscale. Anechoic is no echoes, low attenuators, things are black. This is fluid, blood, bowel, urine, ascites. You can't tell what type of fluid it is, you can just tell that it's fluid. A lot of medicine is fluid where it's not supposed to be. Things that are hypoechoic are gray. They have low levels echoes, things such as soft tissue, solid organs. The lung, when you can see it with pathology, will be gray. The normal lung will have a hyperechoic pleural. But the liver, spleen, and muscle are gray structures. Hyperechoic are white things that dense structures are air. The pericardium is white, periosteum, the diaphragm. Of note, all things in the body will have anisotropic properties, but tendons have increased anisotropic properties. And what that is if you're at 90 degrees, that you get a signal that's a specular reflector, but if you're at different angles, sometimes the sound waves do not return and you can have a change in the appearance of tissue. Tendons, if you're at 90 degrees, will appear white. If you're at 89 or 88, the sound waves dissipate through the fibrillar nature and sometimes will turn dark. It's a property called anisotropy. So this is a bladder that is in a dual screen that we're measuring, and it is black, and the bladder is black, anechoic. And sound waves travel through this and light up the back. This is called posterior acoustic enhancement. The structures behind it are brightened. Again, on B mode or brightness mode, you can see the liver. Here is the kidney. The cortex is going all the way around the calyceal system, so it's in the long axis. We have the psoas muscle in the far field. We have a diaphragm that's hyperechoic on the leading edge. This is cephalad. This is caudal. This is lateral. This is medial. Here on this image is the focal zone. You want to put the focal zone at or below the level of interest. Here's the depth on the side. We're going 16 centimeters down. So it's a pretty decent image. There's no fluid in Morrison's pouch. It's a potential space where fluid can collect. So ultrasound can be used and it can be very helpful. There are artifacts though. The curtain is the pleura as the patients breathe. That's a hyperechoic line. That it is a high attenuator, so it does not allow acoustic window for sound to be transmitted in the far field. So it looks like a curtain as patients breathe and it moves over tissue. A mirror image artifact on the superior surface of the diaphragm when there's air in the lung, that you can have a propagation error and have a mirror image artifact. A curved structure can have a refraction error where there is an edge artifact. In the bladder, in the pelvis, hyperechoic structures coming from the side are side lobes or grading lobes. Behind a rib that's going to be hyperechoic will be posterior acoustic shadowing because it's a strong reflector. And finally, in this image, we see reverberation. This is actually, you can see it says a little bit of scrotum here. This is a testicle in the scrotum, and then we see hyperechoic. It's a bumpy pattern with a dirty gray shadow. So this is gas in the tissue. A lot of medicine is fluid and air where it's not supposed to be. Well, air should not be in the tissue. Bone will be white, but bone will be smooth and white with a clean black shadow. This is bumpy and white with a dirty gray shadow. So everything in the body will have a signature. It's whether you can recognize the blacks, grays, and whites. On this CT scan, we can see that the bone is white. Here we have the tissue in the back going all the way around, and then we get up here and we see some asymmetry, and we see black. This is gas in the tissue in the pelvis that's going from the scrotum and tracking up the patient's body wall. This is called Fournier's gangrene. So this is a surgical emergency. When we do ultrasound, we'll use the probes and we'll see how the ribs are. The ribs are not acoustic window. They're strong reflectors. So we'll try to get in the intercostal muscle. So we'll turn the probe leading edge toward the bed. When we do that, we can get a picture of the kidney. This kidney does not look normal. We have an anechoic area that's circular, has through transmission, and maybe a little bit of enhancement. This is a cyst, a simple cyst. You can see what it looks like on a CT scan. So it's you can see the same pathology on different scans, but radiation can damage tissue, and so it's very important that in the future that we try to image the various structures with safe images for our patients. And I think ultrasound fits that bill. But you can see these same things on CT scans. Here's a picture of a kidney, and there's fluid, not an cyst, but this is hydronephrosis, a spreading of the calyceal system. This is pretty moderate to severe hydronephrosis. Is plumbing as a stone backs up the urine. The urine is black and it separates the calyceal system. Here we see the liver and the kidney with moderate to severe hydronephrosis. Of note, here is the indicator on this machine, again on the left side, but there will be some type of mark that shows what the leading edge is. On this machine, it's a dot. This is over on the right upper quadrant. We see the kidney, and we see a black area here, and this is a positive fast scan. So this is fluid. Do we know if the fluid is blood, ascites? This happened to be a trauma patient in the clinical context, and the patient had a ruptured spleen. We're not seeing the picture as clearly, the superior pole, so we'd have to move to adjust this image. And so when you can move the probe, it's important to understand the various terms of the probe motions. So that's why we wrote a paper on probe motions to clarify not only how to acquire, but then also when we're interpreting images, how to interpret those. those motions that are being performed. So we wrote that there's cardinal forms of motion that we have used and we use in our training, and the goal is to get the probe 90 degrees to the target of interest. That's a specular reflector. You get the most reflection when you're 90 degrees. When you're at other angles, you can get reflection, but you also get some refraction, and so the image may not be as clear. When for example, a vessel wall turns white, the anterior and posterior walls, is because you're exactly at 90 degrees. You're a specular reflector. So that was the goal of having the probe, and understand that at certain motions that you're at 90 degrees. So these are the terms. If you want to center an image, you slide or rock. When you want to interrogate it, you can sweep and fan, and then to go from long to short, you rotate. So let's give you some examples. Here we're on the right upper quadrant, and you can see the person is grabbing the probe and moving in a cephalad direction. So he's sliding cephalad. We see the kidney, we see the inferior pole, the middle, the superior pole. Here's a rib shadow, the liver, the diaphragm, a mirror image artifact. The spine stops at the diaphragm. So when you want to center something, you see it moves from the left to right. This is a slide, and we can see the rib go by, and then the spine stops the diaphragm because there's air in the lower lobe of the lung, and it's attenuating the signal so that you cannot see the spine as it goes above the diaphragm. So we move from the inferior pole to Morrison's pouch to the superior pole with a sliding motion. Now rocking changes the angle of inclination, and you can see how it pivots. So the bottom is moving while the top of the screen, the near field, stays the same, but it's still doing the same thing. Here's the kidney, the rib, here's the diaphragm. So rocking, changing the angle of inclination. If we look at the short axis of the probe, the width of the probe, and we move in that direction, we call that a sweep. So the image will go into and out of the picture. So instead of moving from the left to right, it's going into and out of the picture. So when we're at the mid-axillary line, we see the IVC. When we're at the posterior axillary line, we see the spine. The vessels, the aorta and IVC, sit on top of the anterior to the spine. So as we move from mid to posterior axillary line, we see the kidney come into view. So when we're teaching, if you see the IVC on a right upper quadrant, it means you're too anterior and you need to sweep posteriorly. We try not to use the words move or up and down to try to have the coordinated probe motions. If our probe changes the angle of inclination away from 90 degrees, we call that a fan. And as you can see, the top will stay still and the bottom will move. And you're going in and out of the screen, but you're fanning through a structure such as the kidney. And then finally, you can go from long to short axis by rotating. And you can see when you rotate, you come off the plane. We're rotating, we're seeing the rib coming out of view. Here's the liver, and then here's the kidney. What novices do with these probe motions, they do all three motions at once. Sliding, rocking, rotating, trying to find, and not with a prescriptive method. What we would say, for example, trying to find the kidney, is that you would do a macro sweep, find your target, center the target by either rock or slide. Once it's centered, you do not have to move that direction again. Then ask yourself long, short, or oblique of the kidney, and you're most likely an oblique. So then you have to rotate and fan to get the longer axis. So when we get these images, this is a common maneuver. We will point the leading edge toward the bed, and we'll get this picture of the right kidney, the psoas, the diaphragm, the liver. And this has been helpful because this can help in internal medicine to see if there is ascites. It can help in the trauma patient to see if there is bleeding into the peritoneum. It can help with the patient with flank pain to see if there's hydronephrosis. There's multiple ways that these focused uses can help the patient. On the left side, it's similar. We're going to sweep from the anterior to the posterior axillary line. We're going to center the kidney, and then we're going to rotate the probe leading edge toward the bed. They call this one knuckles to the bed. But a common image that we'll get is that you have the spleen and the kidney, but then you'll see in the far field a hyperechoic area right here. And what this is the stomach. And so the probe is fanned anteriorly just a few millimeters, but just enough that you see the spleen juxtaposed to the stomach. And what's in the stomach? Air. What's the attenuation coefficient? of air? 12. So how do you rectify this? It's a simple maneuver that you fan posteriorly and the rest of the spleen fills into place, and then you have the diaphragm. So as we look at things, if the stomach was full of fluid, it could have potentially been mistaken as a positive fast scan. But the stomach and the bowel will have curved, smooth walls while free fluid takes sharp angles. So you could have, you see that when things are in a container, they're in curved structures. So this is the stomach, and it's a common mistake for people to mistake that and not fan posteriorly. And here that image comes clear. Finally, the fast scan, the bladder image of the bladder should be black as an acoustic window. So in summary, what this talk has tried to do today is to describe the concept of a sonologist, or a person, a learner that is able to acquire and interpret images, and as a clinician is able to use those for medical decision making. This is in distinction to a sonographer, who are highly skilled and probably the best in the world at acquiring ultrasound images, yet their careers do not let them interpret or make medical decisions. At the UME level, or undergraduate medical education, one goal may be to train students to become sonologists in their clinical practice. In 2017, why is 1/3 of medical schools have ultrasound and 2/3 don't? It may be that it has not been branded appropriately, are you trying to train every student to become a radiologist? Are you trying to use ultrasound as an aid to the physical exam? And I think what we're trying to do is give students the skill sets to be able to use ultrasound in their clinical practice. The IAIM technique is a paper that we wrote to try to provide a scaffolding for individuals to perform and to teach an ultrasound exam. Know your indications of why you're doing ultrasound. How do you acquire the images? With getting the patient ready, selecting the right probe, optimizing the picture, completing the protocol, and then searching for pathology. A systematic way to acquire images. When you interpret them, what color is it? What shape is it? Where is it located in the image? And what's it juxtaposed to? Your knowledge of anatomy and your knowledge of ultrasound coalesces, and you become better and better with more exams. And then the probe motions, such as sliding in the long axis, sweeping in the short axis, rocking, changing the angle of inclination to center an image, or fanning in the short axis, allows you to get various planes of tissue and understand what anatomy and pathology is going on. Rotating can go from long to short axis. So ultrasound is a useful tool. It is continuing to grow with the equipment being more portable and affordable. Multiple specialties are using it. The future is early training and a knowledge of the blacks, grays, and whites and how to acquire these images so that we can help our patients. Because as we practice medicine, a lot of medicine is fluid and air where it's not supposed to be. So I hope this was beneficial to a few of you. I know it's somewhat basic to some of the more learned, but I think that there is a definite need to train the next generation, and I look forward to speaking to you again in future webinars. I'm going to search now to see if there are some questions that we can answer for the group. Just one moment. And let me click on, well, Kathy, one of the questions disappeared, but it had to do with a sonographer. Can a sonographer be a sonologist? I think that's what the question was. A sonographer, there is a Society of Diagnostic Medical Sonography that sonographers join, that they get their certification through the ARDMS. I have my own RDMS. I'm an MD in RDMS. A sonologist has to be able to interpret and then use it for medical decision making. And sonographers only acquire. There was an advanced practice sonography degree back in the past, but I don't know if that is continuing. But these terms, I want everyone to know, sonographer is pretty standard, but sonologist, if you look through the literature and you look through dictionaries, there's not definitions of those. And so where there's a vacuum, I'm putting something out there. It's not written in stone, but there's not a lot of clarity as far as what a sonologist is out in the literature. So I'm describing it as somebody that can acquire and interpret images. I think traditionally it was for a radiologist, to a term that was for radiologists that was able to acquire and interpret ultrasound. But again, I cannot find any official definition of this in my searching. So if anybody has information, that'd be helpful. I have a note from Mohamdani Ali that the image interpretation in the screen. I'm not sure. If he wants me to go back to that, the image interpretation on when you look at an image, the image interpretation, when you're looking at something, there will be certain patterns that you'll start to recognize in certain shapes. For example, on this image, the vertebral body is curved. It's in the far field. It's hyperechoic because its bone has a strong reflection. It has a shadow behind it. On this image, we're actually imaging through the disc, and you can actually see the spinal cord. So image interpretation is really going to be based on your knowledge of the anatomy plus the sonographic signatures. How can we know anterior to posterior? Well, I think that if you put up a chest x-ray and the heart is on the right side of the image, then you know that that's correct. It shouldn't be on the left side. So there's certain patterns. I think there's certain standard image. I showed that right kidney a few times. The only way you know anterior and posterior is if you can recognize what structures you're looking at. A couple of my slides had the probe and the picture next to each other, but you won't know. In general, the top is going to be anterior when you're scanning, but sometimes we'll scan from the back of the leg for vascular studies, or actually look for pleural effusions. So that's why I try to use a body pattern, and I'll put body patterns on so to tell where the probe is, so that the image speaks for itself. Are there any other questions? Please, if you have some, if you want to type those in. We still have a few more minutes.
It looks like that might be all we have right now, Dr. Bahner, and so it looks like you answered most everyone's questions as you went. So thank you so much for this wonderful presentation. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.
Thank you.